Now I'd like to hand things off to Donna to get us started.
Hi, thank you. I'm Donna Uris. I'm the branch chief for the Behavioral Health Services Act branch at Department of Healthcare Services, and I'd like to welcome everybody again to the call. So today's session is focused on guiding you through the process of completing the integrated plan template. Our goal is to provide clear instructions on how to fill out various sections of the template so that you feel confident in submitting your county's integrated plan. Please note this session will not cover the policy background or rationale for the questions included in the IEP. And for all policy related information, please refer to the county BHSA policy manual. We encourage you to ask questions throughout the session, again, using the Q&A box. And we've set aside time to address your questions. Want to make sure you leave today with the information you need to complete the template successfully. Next slide. So today we'll walk through the key components and milestones for submitting your integrated plan. Our goal is to help you understand each step in the process, what's expected along the way. We'll start with a quick overview of the submission timeline and the community planning process, then review some of the data sections in the plan, and we will also walk through the statewide behavioral health goals section, as well as the county provider monitoring and oversight section. And then we'll touch on some next steps for future webinars. Next slide. Okay, one more, please. Perfect. So the submission timeline is anchored by two key deadlines. One, draft IPs are due March 31st, 2026, and final IPs are due June 30th, 2026 for the fiscal year 26-29 cycle. So drafts must include a letter from the CAO and approval from the behavioral health director, including the exemption and transfer requests. Early and complete draft submissions allow DHCS to provide feedback, review exemption transfer funding requests, and support timely plan finalization. Counties are required to provide 30 days for stakeholder comment on each draft IP. And the local behavioral health board is required to conduct a public hearing on the draft IP at the close of the 30-day comment period. DHCS staff have 30 days to review the draft and final IPs. Missing submission deadlines could trigger corrective action or temporary holding of BHSA fund distributions, which this just underscores the importance of timely compliance. Next slide. So DHCS will review draft and final IPs for completeness and adherence to policy requirements prescribed in the policy manual and statute within 30 calendar days of submission. If DHCS deems a county's IP or annual update does not address a question directly or is inaccurate, DHCS will contact the county through the county portal to rectify and resubmit the integrated plan. We'll contact the county through the portal. Let's see. Oops, hold on a second. Losing my place here. If DHCS requests the county revise their draft IP, the county will have 15 calendar days from the revision notice to address the issues raised by DHCS and then resubmit through the county portal. DHCS then has 15 days to review and respond to the submission. Our goal is to have all of the plans submitted and accepted by June 30th, which is a requirement in statute. Next slide. So counties are advised to submit the draft IP in advance of the deadline if possible. Early submission just provides additional time to address any feedback from DHCS and make any necessary adjustments. When submitting the draft IPs, again, please provide complete responses to all the questions that are required and be sure to include the budget workbook. And hopefully that can be as close to the final version as possible. This comprehensive approach enables us to provide more targeted and relevant feedback. DHCS will communicate all the feedback on the draft IP as well as decisions on any exemption or funding transfer requests through the county portal. So counties should regularly check the portal for updates and respond promptly to any requests for revisions. If we do request revisions to the draft IP, the county must address those revisions before submitting the final IP. This step is essential, and it really helps to align the plan with state priorities and requirements. And it also helps with workload, I believe, on the county side as well as the state side. Next slide, please. So for the final submission, counties do not need to create an entirely new integrated plan. The county portal system will track any changes made to the accepted draft IP through portal functionality. This streamlines the process, reduces administrative burden on the county side. Before submitting the final IP, counties must allow a 30-day comment period for public review. And this can occur before submitting the draft IP or prior to submitting the final IP, providing flexibility in the planning timeline. The local behavioral health board again plays a vital role in the process. They're required to conduct a public hearing and review the draft IP, providing recommendations for improvement. And this process allows for expert input and community insight. Counties again must include substantive written recommendations and a summary of revisions made in response to stakeholder feedback. This demonstrates how community input has shaped the final plan and promotes accountability. For a final IP to be considered complete, the county must include a response to each required item in the IP, must include the certification from the county behavioral health director, ensuring that the counties comply with all applicable regulations, laws, and statutes, and include the certification by the county board of supervisors. Next slide. So this slide, it's just a different way of looking at the information that I've already provided you. We've put it in a table format to make it a little clearer, exactly like what is included with the draft or what's required to be included in the final IP. All right, and the next slide. So that brings us to our first round of questions. If you have any questions, please raise your hand. And we'll call on you.
All right. I've got a hand. It's not popping up for me right away. Give me 1 second. Vivian, that's actually not showing up for me up top.
Don't see any raised hands.
Okay. Oh, there it is. We have Suzanne Tavano.
Hi, yeah, and maybe it's too soon to ask this question, but now that the portal is open and we're registering users, etc., can we be entering components of the IP as we go along for feedback rather than waiting until there's a full draft IP? For example, if we've completed the community planning process, can we start loading that in? If we've estimated the number of ACT, FACT teams, etc., or do we have to have a full draft before we could enter for feedback?
Great question. You do need to actually have the draft completed before it can be submitted to the department. That said, you're definitely able to go in and start filling out the draft IP, but DHCS can see the progress, but we aren't able to see you working in the draft document. So once that's completed, and all the fields are filled in, you'll be able to press the submit button and it'll alert us that the plan has arrived and ready for review.
Thank you. So we wouldn't be able to get feedback as we build the IP. We have to wait until it's completed.
Yes, that's correct. That's
Okay,
the way that the portal operates. Sure.
Thank you.
Any other questions?
We did have some in chat, and I don't want to make a habit out of asking them out loud, Donna, but this one may be helpful. Is there an earliest date that the draft IP can be submitted?
We can take the draft IP at any point in time. We are ready on our end.
Thank you. I don't see any additional raised hands right now.
I'm going to move to the next slide. And one more. Thank you. So the BHSA expands upon the MHSA planning process. It aims to create a more comprehensive assessment of community needs and promote stronger collaboration across different systems. This leads to more efficient resource planning and better coordinated services for individuals with behavioral health needs. The required stakeholder list is designed to promote broad community representation. It specifically includes populations at greatest risk for experiencing behavioral health disparities. By including diverse voices, the planning process can better address the unique needs of all community members and promote equitable access to services. I do want to take a minute to point out that Cal Mesa offers a guidebook to assist counties with the community planning process. The Meaningful Engagement Guidebook and a related webinar are both available on Cal Mesa's website. And these are amazing resources and practical guidance for conducting effective community engagement process. I would highly encourage you, if you haven't already seen these tools, to look at them and review the material. I think it will be helpful. Next slide. So this serves as a reminder to assist the community planning process and staffing. The county may designate positions and/or units related to the overall community planning process. Counties can use 5% of their BHSA revenue to support stakeholder engagement. And use of the funds could include, as I just mentioned, staffing and training. It could also include planning costs if you need any infrastructure or technology, if you need some sort of web-based meeting platforms to roll out your planning process. It can also be used for stakeholder support, such as stipends or wages, travel and transportation, as well as childcare and elder care. Next slide. So the BHSA emphasizes collaboration with local planning efforts as part of the community planning process. And this involves aligning the integrated plan community planning with various, with the local health jurisdiction, the CHA-CHIP process. So starting in January 2025, counties will collaborate with their LHJs and managed care plans to develop the CHA-CHIP. This collaborative approach promotes alignment of priorities and resources across different sectors. Required areas of engagement include collaboration, data sharing, and stakeholder activities. Counties are encouraged to work with their LHJ to streamline the processes and reduce community fatigue. By coordinating planning efforts, counties can minimize duplication and maximize community engagement. For the 2026 IP submissions, counties may consider the most recent LHJ CHA-CHIP or strategic plan when developing their IP. The integration of local health priorities will help to ensure that the IP is responsive to community needs. As a note, the Department of Healthcare Services is planning to release a BHSA local planning process collaboration tool to support counties in meeting these requirements of working with their LHJ and the MCPs. Use of this tool is optional, but it may provide valuable guidance and resources for collaborative planning. We are hoping to release this tool during fall of 2025. Next. All right, our next round of questions.
We've got a hand from Louise. We'll go ahead and get you off mute.
I did ask a question in the Q&A for the previous section, but it didn't get answered. So you mentioned that the slide shows the public comment period can be prior to submitting the draft or prior to submitting the final. Can it occur whilst the draft is being reviewed by the DHCS during that period of time?
Yeah, you would be reviewing, it would just be, it would be similar to reviewing before the draft was submitted.
Right, that's what I thought. It just seemed very specific, and I thought, oh, okay, I just thought I'd check.
Sorry.
That's okay. So basically, anytime the draft is ready through to the time when the final is submitted, there's a 30-day comment period, anytime during that period.
Yes.
Okay, thank you very much.
Great question.
Not showing any other raised hands right now, Donna.
All right. Let's move on to the next section then. Okay, so the IP data requirements are designed to support both compliance and continuous quality improvement, providing counties and stakeholders with actionable insights for planning and resource allocation. So data submitted in the IP forms the basis for identifying service gaps, tracking disparities, and aligning those local priorities with statewide behavioral health transformation goals. Counties are expected to use the most recent and relevant data sources as specified by DHCS to reflect current conditions and inform both short and long-term strategies. Next slide, please. The integrated plan is a forward-looking tool, so it's used for planning, obviously. The data included should guide county planning and spending to address community needs, reduce disparities, and achieve outcome measures. By requiring data from the fiscal year prior to planning, DHCS supports counties in grounding their strategies in the most up-to-date information available, which is critical for effective community engagement and plan developing. For the 26 to 29 IP, remember that data will not be pre-populated. Counties should begin this process early, utilizing available resources and technical assistance to support a comprehensive and accurate data set. We do understand, as I mentioned, that it's important to use the most recent data that you have available. If that is not for the year prior to the IP planning, then it's okay. Just use whatever is most current. Next slide. The integrated plan relies on relevant local data to inform county strategies. While counties have the flexibility in data sources, prioritizing data from the most recent fiscal year helps the plan reflect current community needs and service gaps. And this approach aligns with the state's emphasis on EBPs and data-driven decision-making in behavioral health. We're also encouraging stakeholders by leveraging that IP data. Sharing a clear assessment of behavioral health gaps fosters collaborative problem solving and helps prioritize interventions that address the most pressing community concerns. Next slide. So the integrated plan relies on, why do I feel like I'm saying the same thing again? Hold, please. Let me look at my notes. So on this slide, okay. Counties are responsible for reporting relevant data within their integrated plans to reflect the community needs and service gaps. When counties submit joint integrated plans, the data presented must reflect the combined population and service landscape of all the participating counties. And this consolidated data set provides a comprehensive view of the region's behavioral health needs and resources. And cities participating in the IP process are expected to submit data that corresponds to the specific county in which they're located. And this ensures data alignment and facilitates a clear understanding of behavioral health trends within each county. Next slide. Okay, so data in this section is organized by grade age groups, specifically focusing on children and youth under age 21 and adults and older adults. This stratification allows for a targeted analysis of the unique needs and service utilization patterns within each population segment. So while the BHSA prioritizes children and youth under age 25, counties will actually utilize Medi-Cal data for certain reporting requirements in the IP. And as a result, data for children and youth will be reported for those under age 21 where appropriate to align with available data sources. Next slide. A primary long-term goal of behavioral transformation and other DHCS initiatives is to improve data sharing among traditionally isolated entities. So enhanced data sharing is expected to lead to better coordinated and more effective care delivery. Improved data sharing leads to better care and outcomes and supports a data-driven, value-based healthcare approach. This approach emphasizes the use of data to inform decision-making, improve service quality, and maximize the value of investments in behavioral health. For the integrated plan, counties will provide information on housing availability, service utilization, and justice involvement data. This comprehensive data set will provide a more complete picture of the factors impacting the behavioral health outcomes in the community. So counties should make a good faith effort to obtain updated information from relevant county partners who may possess this data. Collaboration and data sharing with other agencies is essential for developing a comprehensive and accurate integrated plan. Next slide. All right, back at questions.
While we wait for hands, we did have a question in the chat about if the slides were going to be available to the group.
Yes, we're working on remediating everything. And then I believe the slides will be posted on our DHCS website.
Perfect. And then we do have a hand from Louise.
Hello, me again. I have a question in regards to so we just submitted our last annual update, which was reporting on fiscal year 23-24, and that's just been submitted recently. I've been told that we're supposed to do another annual update to report on fiscal years 24-25, but when I started looking through the integrated plan template, I noticed that it was asking for preceding data, but it didn't indicate on the integrated plan template what fiscal year that was being reported. It just said how many were served over what period was the question in my head. So sort of a two-part question, really. What period are we reporting in terms of the recent past, recent data? And do we have to do another annual update in between now and submitting the integrated plan?
So the most recent year of data is what we're asking counties to provide. So whatever that most recent complete year of data is for you is what you would provide when answering those questions and filling in the data, like how many children have you served through your specialty mental health services. That would be whatever your most current year of data is. We understand that may or may not be the same fiscal year all the way down that list of the types of data where you're asked to provide, but we're just telling counties, please use whatever's most current.
Okay.
It's really important for your stakeholders to have an understanding and to be transparent with, like, this is what we're actually doing right now. This is the numbers that we're serving and that sort of thing. So that's why it's important just to try to get the most recent data that you have available.
Okay, so basically data from the last point where we reported to the DHCS.
Mm-hmm.
Yeah. So any new data that you haven't yet received is what I'm trying to say. Does that make sense?
What I've been told and what I'm telling everybody is use whatever is most current. So if you have the data and it's most current, then please use it. If it hasn't been submitted to DHCS and you still have it, great, use it.
Okay. Thank you.
And then as far as the annual update, that still is an MHSA requirement. So I believe that is still happening, but we can certainly double check on that. And I will be sure to reach back out or include that as part of our FAQs.
Thank you, because, I thought I'd done the last one and now we were moving on to the IP. So I was like, oh, there's one more. Okay.
Great question.
Thank you.
All right, we have a hand from Oliver Gonzalez.
Yes, hi. I just have a follow-up question with what Louise was just asking around the annual update for MHSA. So for us here in Humboldt County, one thing is we're actually due to do an MHSA 3-year plan. So are we supposed to do a 3-year plan MHSA and then on top of that an IP? Because that doesn't seem practical for us.
No, we definitely would not want that happening. I think what I will do is reach out. Julia, are you on the call? Julia is part of our policy team. And I know that we've talked about this in the past. Are you able to respond to that?
Yeah, and I think maybe there might also be some layers of confusion because of the extensions that were granted during the COVID emergency. I know that in general terms, there is the annual updates are only for the previous 3-year plan, right? And so everybody's plan should be ending 7/1/20 or June 30th, 2026. and the next 3-year plan is going to all be the same for requirement for everybody and will be the integrated plan. Now, some plans that had the extension may have ended up being in a 2-year plan, but there should be an annual update for 24-25 and an annual update for 25-26 of that 23-26 3-year plan. So I know that if a county has submitted their annual update for fiscal year 25-26 and it included data from fiscal year 24-25, that's the last update. It still sounds confusing as I'm saying it myself. So if there are any questions about the integrated plans and the annual updates, you can still, that are for MHSA and are not BHSA requirements, you can contact us at the MHSA inbox and we'll help figure out exactly what county you are, what plan, what track of plan and updates you have, and can give you better individualized responses that way.
Perfect. Thank you, Julia. I just really wanted to verify that. We did do our 25-26 annual update here in Humboldt, so just wanted to make sure I didn't get a mini heart attack for a moment there.
Sure.
All right. We also have a hand from M. Padilla. I show you off mute. Can you hear us? Not seeing any audio come through on this one, maybe having technical difficulties.
Hi, do you hear me?
I can hear you a little bit. It sounds like you're far away though.
Oh, I have my volume up. Does this sound better now?
Yeah, much better.
Thank you. So my question is about the fiscal year where the data that counties will be reporting will be coming from. At the recent CBHDA webinar that I attended last week, it was mentioned that for the behavioral health system overview questions, counties will be reporting on data from fiscal year 23-24. So just wanted to get clarity if that's still the right approach for the county to provide data.
Yes, because we're right now in 25, so we don't have data for 25-26, and the data from 24-25 may not be available yet. So that's why we were specific to 23-24. We believe that would be the most recent data that counties would have available. But if they do have 24-25, then we would encourage the counties to use that data instead.
Gotcha. Thank you, Donna.
Sure.
I have no additional hands.
Okay. So at this point, oh, next slide. Okay, so at this point, I'm going to hand over the presentation to Anna Nafee, and she's going to walk you through the statewide behavioral health goals section. Anna?
Thanks, Anna. I'm Anna Nafee, and I'm the Quality and Equity Workstream Lead for BHT, and I'm working on the measures if I haven't met you already. So we'll talk a little bit about the statewide goals and how we anticipate using those measures from phase 1 in the integrated plan. We can go to the next slide. So I think you all know by now we've established these 14 behavioral health goals to help guide our system in identifying what we want to achieve with behavioral health and the areas of focus across our behavioral health systems. We're thinking about this not only for the county behavioral health system, but also for managed care plans and even aligning with public health and other areas. So these are the big population level statewide goals for behavioral health. We can go to the next slide. To support the planning process, we are asking counties to look at the statewide measures for the phase 1 measures that are population level for the most part associated with each of the goals, and compare yourselves to the statewide rate. There are 6 priority goals that we've selected that really line up with the priority populations of focus in SB 326, as well as 2 areas of focus that we want to encourage, which are access to care and untreated behavioral health. And then counties also have the opportunity to, or are required to select one additional goal that is based on both local need and data, that areas where counties choose to focus their programming and services, and they will write plans to address those priority areas and statewide goals. Additionally, and this is also required in the SB 326, counties are asked to identify disparities and choose data-informed strategies to improve community health and well-being for the 6 priority goals and the 1 additional goal. You can go to the next slide. So the priority goals are listed here with the asterisks, and most of them, as I said, are those priority populations: institutionalization, homelessness, justice involvement, removal of children from home, as well as the 2 areas of focus that we want to see improvement on statewide, which is untreated behavioral health conditions and access to care. We can go to the next slide. And so in terms of the measures, we went through a process with our Quality and Equity Advisory Committee and engaged the public to identify population behavioral health measures that are publicly available that are meant to assist with completing the first integrated plan. Now, these are sort of stopgap measures. We're working on phase 2 now, which are another set of measures which will calculate. These phase 1 measures are really just the measures that we want to use to focus planning, allocate resources, and we wanted to choose measures that are publicly available so that anyone in communities can access the data and understand the landscape of areas of need within the community. Each goal has about 1 primary measure. There are some exceptions to that. And then about 2 or 3 supplemental measures. The primary measures are the ones that we want to be the point of reference that reflect the community's status and well-being. And the supplementary measures are ones that we wanted to include. We thought are useful contextual information, but not necessarily where you're comparing yourself to the statewide rates. And so we put together a performance workbook where we pulled all of the data from all of the different phase 1 measures. In some cases, we calculated some of the rates, and we've had some questions about those calculations. We're working to respond to those questions. And we did that because the rates were not publicly available, like a unified rate. Sometimes there were rates that where you had to already stratified by demographics and that sort of thing. And then the links and the access to the measures are in the document, the instructions document. We understand that the links sometimes will change as data gets updated. So we do try to re-update those when we can. But for the most part, the population workbook is also a source of truth to look for both your own county's rate and the statewide rate. But in order to identify disparities, oftentimes you do have to go to the public website. That's where the disparities data is located. Go to the next slide. So we have an example here of the a primary measure associated with access to care. And this is a penetration rate measure. This is an example of one that we did calculate, but the publicly available measure is on the DHCS website for non-specialty mental health. And so there are a couple questions to answer. How does your county compare to the statewide rate? We want to answer for both adults and children, and then what disparities do you identify? And these, the drop down will be different depending on what's available in the publicly available data. So the stratifications are not ones that we've developed, but ones that are in the original data source. We can go to the next slide. So then you'll use the measure access instructions document to locate the data source and review the measure description as well as any related notes or guidance. So we tried to be really, really clear about where to find the data, what to look at, and have a measure description for each of the measures, the phase 1 measures. We can go to the next slide. And then in the population level workbook, you would navigate in this example to access to care. Again, like I said, we calculated both a statewide rate and a statewide median just for ease of reference. And then you follow the prompts, find your county's rate for the corresponding measure and compare it to the statewide rate. And we can go to the next slide. So in order to identify disparities, we ask counties to look at and identify disparities for the 6 priority goals and then the 1 self-selected goal, and ask you to review and identify what those disparities are. Want to also say that supplemental local data is very much encouraged here. We know that you all have a lot of data that you use already, and that can be really informative in this process. And we can go to the next slide. So then we expect counties to review and reflect on your community status where the data is available. If there's not data for a specific measure, then you don't have to answer the question or address it. There are some gaps. And in fact, under the institutionalization goal in the administrative bed days data, I think only 9 counties have that data reported. So there will be gaps. So we don't expect people to respond there. And to support planning and address local needs, you can use your own data to supplement as well. And you can describe that in your description of the plan. We can go to the next slide. So based on this review, you'll select and describe any data-informed initiatives aimed at improving the status of the goal, and then identify both BHSA and non-BHSA funding sources that support these. So on the next slide, I think we have a little bit of information of what that looks like. Oh, maybe not. Okay. Any questions?
Not seeing any raised hands as of yet.
Okay.
I have a quick question. I'm wondering, just to follow up on something that you said, Anna, and I'm actually wondering if Carson or someone from the product team is available. Because I know that you had mentioned there may be some counties where the data is not available, and the plan would be to not require the counties to have to include anything. The data is not there. Obviously, that makes sense. But I want to make sure for the portal, is there the ability to, should the counties, if there is no data, should they write like no data? Should they write NA? I think we need a response for each question.
Okay.
And so that's why I think it would be helpful. If they're not on, if product isn't on the call, we can bring that back and ask them.
It looks like we do have a hand from Karina as well.
Okay, Karina would work.
I think the hand went away. Oh. Okay, let's go with Karina first if we can, and then we'll go to Louise after.
Donna, I'm from the product team. Just providing a little bit of background. All questions on the integrated plan are required unless specifically noted as optional. So in the event that someone would not be able to speak to any data or fill that out, they could probably simply put NA in their section so they can submit their integrated plan.
Yep. Thank you.
Hello,
Thank
this
you.
is Carson from product team as well. We would also, recommend if you do have a question on how to complete a question in the integrated plan or anything like that, to use the support center to make that request, and we can help clarify it from there. If you have kind of further questions or need help understanding how to potentially answer a question.
Perfect. Thank you, Carson. Louise, if you're ready.
Yes, I was just wondering, further to all that, whether it's possible to have some kind of drop-down menu with standard answers.
For which questions?
Well, as in if it's NA, for example,
Oh,
or that kind of thing.
Yeah, that's what I'm not sure of. I know, and obviously if there's something that you need to type in, you could easily do NA. I think, Carson, we might need to think about that or look at if that is an option for some of these data boxes where your choices are like above or below. Like we would need to figure out if that's if there's the ability, if it is a drop down and it doesn't reference NA or not available or something, it would be hard. The counties would not have an opportunity to answer that question. If that makes sense.
Yeah, I think we can kind of take that back and look at where we can make improvements there.
Great.
All right. We also have a hand from Tracy.
Thank you. I had put my question in the chat around if there's going to be a data dictionary that's going to be provided. I know we're on the behavioral health goals section, so this was a question from before, because we are noticing for some of the questions where you would like, or we are required to enter number of individuals served with a particular context. An example for me is on hard copy page 15 of the IP. It asks for the number of individuals who are re-entered the community from prison or county jail. But our data teams are having a hard time really understanding what the state wants in terms of that number. So there are a number of questions like that. And so I had brought this up and other counties had brought this up during our testing of the portal, which is lovely. It's very easy to use. Thank you. But we're just still curious about that data dictionary piece so that we can get you the information that you want, so that then this information can be shared, or aggregated across counties.
Sure. That's great feedback, and I can take that back and see if there's something that we can put together that will help.
Okay, thank you.
Yeah,
and I apologize, that was a long question.
No worries. No worries. It's not something that we have completed at this point. So we'd have to do it, but it's not something that, it's doable. So
Great.
I'll take it back. Thank you.
Thank you.
All right. No additional hands at this time.
Right. I will take back the presentation then. Thank you, Anna. All right. Next slide, please. Moving into the county provider monitoring and oversight section. So in this section, counties are required to report the total number of contracted BHSA provider locations, with each physical site counted separately, even for multi-site providers or multiple programs within a single building. So this granular reporting supports DHCS reviews and helps identify geographic or programmatic gaps in service delivery. So I want to point out that for these two tables, for a multi-site provider, the counties would count each site as a separate provider location. And for different programs that were in the same building, those also would be counted as each of those would be counted as separate provider locations. Next slide. So counties must analyze the extent of overlap between specialty and non-specialty mental health service providers using DHCS network adequacy reports as a baseline. So DHCS will supply counties with this data on the percentage of specialty mental health service provider locations contracting with managed care plans for non-specialty mental health services, and counties must analyze and report this overlap in their IP. We are hoping to provide this data to the counties in fall of 2025, and it will be some sort of a workbook that will have, I believe it'll either have 2 or 3 data sheets in it, and it will be provided to each county. We're figuring out the best way to, the best format to provide that to the counties because there may be some secure information in there. So we want to make sure that it's not, we probably won't just be emailing it out directly or posting it. Next slide. So counties have the flexibility to describe alternative monitoring schedules in their IP, but they must demonstrate that their approach supports accountability and continuous improvement. So robust monitoring practices are linked to our broader oversight and TA framework, with the county portal facilitating documentation, communication, and resolution of compliance issues. So for this one, like I said, if you choose to adopt your Medi-Cal provider monitoring schedule, that's great. If you don't want to adopt that schedule and you want to have something slightly different, that's fine too. Just remember that it needs to include some sort of periodic site visits. Next slide. Questions?
No hands as of yet.
Okay. So the next slide is our kind of our final slide for today's presentation. So I don't know if there are other questions.
It looks like we had one
Just in
pop from
general?
Tracy
Okay.
with a hand.
Thank
Perfect.
you. I did, thank you, Donna. I had a question when, on the monitoring schedule, is there information, or maybe it's in the policy manual, on what we should be, this might be a very basic question, but, and I could ask our contracts department, but is there something that DHCS is specifically looking for us to monitor to? Like, are they billing to Medi-Cal? Are they meeting their contract requirements? These are all things we already monitor to, but is there something other or information or context around that monitoring definition?
Great question. This piece, I don't have the answer to that question because this is something that's handled, these particular pieces outside of our normal section. But I can certainly look into that, and we can provide a response in our Q&A.
Thank you. Thank you. That's very helpful.
Yeah, sure.
No additional hands.
Okay, so let's move to the next steps. And one more slide.
We did get another hand down. Did you want to address that?
Sure.
All right, Suzanne. Suzanne, I'm showing you on mute.
Sorry, that was an error.
Oh, gotcha. Thank you.
Okay. Well, the next slide presents the kind of the schedule of events that are upcoming. We have a couple of more webinars where we're going to walk through a couple of, the rest of the integrated plan template. On our presentation on Thursday, we're planning on walking through the BHSA components. So that would be FSP, housing interventions, and BHSS. And then in our final webinar, which is scheduled for August 26th, we're planning on talking about the fiscal budget workbook, funding transfers, exemptions, and then the integrated plan review process. So a little bit more information coming on that. I also want to point out that we do have, we've been adding some technical assistance materials to our website. And if you have not checked out our website yet, I would highly encourage it. We have, I believe we've posted a frequently asked questions document. We have a couple of videos put together to help counties in completing the budget workbook. And then we are working on a budget, like a guide for completing the budget as well. That's not quite ready, but that's coming up. And so, like I said, I would just encourage you to continue checking on our website for additional TA tools. We're also encouraging counties, please submit all your questions through the support center, which is located within the county portal. Any questions that you have on how to complete the plan, running into error messages on the portal itself, please submit those to us, and we will certainly, we're here to help you on that as well. So again, I want to just thank everybody for attending today, and I will give you back about 30 minutes of your time.
Donna, real quick, sorry. We have a couple of questions in chat asking about the links to the August 14th webinar as well as registration links for the other webinars. Do we have any info on those?
Maybe is Emma from comms, can you reply to that?
Yeah, I think I can drop that in the chat here, and we will be getting a reminder out shortly.
Okay. Anything else?
That's all we've got that seem to be consistent. Others in the chat I can respond to as we have them.
Okay.
Yeah, I think we're good, Donna. We just got a couple questions that are general in the chat, so I'll address those in chat.
Okay. Thank you. All right.